So I'll be talking about approach to disorders of sex development. We had a bit of discussion on this in the pre-lunch session, one of the case discussions. So what do we mean by disorders of sex development? So these are a group of congenital conditions in which the development of chromosomal, gonadal, or anatomical sex is atypical or abnormal. And please remember, DSD is an umbrella term. It includes the cases not only with ambiguous genitalia, but also the ones which are associated with primary hypogonadism. Previously, we used to use these terms, not us, but generally these terms were used: intersex, sex reversal, hermaphroditism, pseudo-hermaphroditism. But nowadays, it's considered best to avoid these terms because they are quite controversial and they're considered to be derogatory and not very proper to use. So please avoid using these terms. So it's best to refer to all these conditions as DSDs. So ambiguous genitalia, though again, it's better to avoid that term and probably you could just call it a genital anomaly. But as such, the conventional definition of ambiguous genitalia is that it's a congenital defect where the appearance of the external genitalia is at variance with what is normal for either male or female sex. So any one or more of these features could be present. The phallus could be intermediate in size between a normal penis and a normal clitoris. You could have an aberrantly located urethral opening, or in an apparently male individual, you can have at least one impalpable gonad. In order to understand why these DSDs happen, we have to go back to our physiology days. So we have to understand the physiology of sex development in order to understand why these DSDs happen. So basically, the gonads develop from the embryonic precursor, which develops from the urogenital ridge approximately day 32 post-fertilization. And till the 6th week, gonads remain bipotential. And there are two sets of internal ducts initially: the Mullerian duct, otherwise called the paramesonephric duct, and the Wolffian duct, otherwise called the mesonephric duct. So this sex development is actually a two-step process. First is sexual determination, and second is sexual differentiation. Sexual determination is the step where there is the formation of the testes or the ovary from the primitive gonad, and differentiation is when the internal and external genitalia differentiate by the action of hormones secreted by the fetal gonad. So, as I said, till about the 6th week of embryonic life, the gonad or that initial precursor is bipotential. But after that, the gonadal determination begins. So actually, what happens in the 46XY embryo is that it is the SRY gene which is present on the Y chromosome which begins this determination process. So it encodes a transcription factor, and this activates the downstream testes forming pathway. There are a number of other genes downstream, such as the SOX9 gene, NR5A1, GATA4, WT1, SOX8, AMH, and so on. So all of these are actually activated by the action of the SRY. So if SRY is absent, this would not happen, and hence testes formation would not happen. In the 46XX embryo, the absence of the SRY results in this pathway not happening, and instead the alternate pathway happening, where you have these other genes such as Wnt4, RSPO1, and also NR5A1 is involved here as well, and many other downstream genes. They all contribute to the formation of the ovary. So once the testes and the ovary are formed, the fetal gonad starts secreting hormones. So in the testes, you have the Leydig cells and you have the Sertoli cells. The Leydig cells are the ones which actually produce testosterone, and Sertoli cells produce AMH, the anti-Mullerian hormone. Testosterone is required for differentiation of the internal gonads in the males into epididymis, vas deferens, and the seminal vesicles. And testosterone gets converted to dihydrotestosterone by the action of this enzyme called 5-alpha reductase. And DHT is the thing that acts on the external precursors and is responsible for the differentiation into the male external genitalia. For this, androgen receptors are also involved. And so whatever initial tubercle, genital tubercle is there, that differentiates into this entire external genitalia in the males. And the Sertoli cell is responsible for the production of anti-Mullerian hormone. And this actually results in the regression of the Mullerian structures. And that's why these Mullerian derivatives like the uterus and the fallopian tubes do not form in the males. Now, this is just a reiteration of what I just said, that testosterone gets converted to dihydrotestosterone, and then it acts on the external genital precursors and is responsible for the external genitalia being formed, and all the typical virilization which is seen in males occurring is because of this DHT. Now, over here, if you see, the external genitalia in the presence of the DHT differentiates into the typical male external genitalia. But if testosterone is not there, DHT is not formed. And as a result, there is a default development into the female pattern external genitalia. So coming back to, so having understood the basic physiology, now it's possibly easier for us to understand why these disorders of sex development happen. So DSTs are actually classified into three main categories. And of course, there are other classification systems used, but this one is the more conventionally used classification system, which was given by the Lawson-Wilkins Pediatric Endocrine Society and the European Society for Pediatric Endocrinology. As per this, DSDs are classified into three broad categories: the sex chromosome DSDs, the 46XY DSDs, and the 46XX DSDs. So I'll just elaborate on each of these things in the subsequent slides. So what do we mean by sex chromosome DSDs? So these are the disorders of sex development where there is a numerical sex chromosomal abnormality which can be picked up in karyotyping, and this is what leads to the abnormal gonadal development. So most of these individuals have gonadal dysgenesis. Usually, if it's a poorly formed testis, it is called a dysgenetic testis, and a poorly formed ovary is usually referred to as a streak gonad. And the most common sex chromosome DSDs are actually Klinefelter and Turner syndrome. But Klinefelter and Turner, neither of them, please remember, present with ambiguous genitalia. Neither of them has ambiguous genitalia. Both of them present with primary hypogonadism. So the manifestation mainly will be as delayed secondary sexual development. So Turner syndrome is actually quite a common sex chromosome DSD, which affects about 1 in 2,000 to 2,500 live female births. 50% of them have monosomy X, where only one X chromosome is present, and the rest of them are actually mosaics, where you can have 45X along with another chromosomal complement, or you could have a partial X chromosome deletion, not the entire thing. So you have various things like ISO, XQ, and so many other patterns happening. So the classic form of Turner syndrome usually presents with amenorrhea. They do not have ambiguous genitalia. Most of them have normal intellectual development, normal cognitive functions, and delayed secondary sexual development is the usual manifestation. And of course, almost all of them have short stature. Of course, the Turner stigmata that we all are very familiar with may not always be present in all affected individuals. And mosaic patients can have a very variable phenotype depending upon the proportion of cells which have the normal chromosomal complement. So some of them may present with only premature ovarian failure and nothing else. They may have normal height, they may have initially normal secondary sexual development. Subsequently, they can go on to have premature ovarian failure. The mosaic individuals who have a larger proportion of normal cells, 46XX cells. And yes, just to again re-emphasize the fact that they do not have any genital ambiguity, but this is a DSD because, as I said in the beginning, DSD is an umbrella term which encompasses the primary hypogonadism conditions also. So these are the typical Turner stigmata that you could see. So a girl child presenting with short stature, you can appreciate the webbing of the neck, you can appreciate the cubitus valgus deformity, the short fourth and fifth metacarpals, and also the low posterior hairline, which is not seen over here. And in fact, this girl also had coarctation of aorta. They can also have renal anomalies, especially horseshoe kidney and others. And she had 45X, the typical classic Turner syndrome complement. So, but as I said before, all individuals, all girls with Turner syndrome need not have this typical stigmata. That is why any child with girl child who presents with unexplained short stature, even in the absence of, all these Turner stigmata, we should do karyotyping to check for and rule out Turner syndrome. Now, this is another clinical scenario where we have a 25 years old lady married for 3 years, and she presented with primary infertility. She's also having secondary amenorrhea for 5 years. She did have some degree of short stature. Her height was 142 centimeters, but no other clinical abnormality, no Turner stigmata, nothing else. But then her FSH, LH were high, and she was found to have premature ovarian failure. And when we did the karyotyping, we found that she was actually a mosaic Turner, where you can see both types of, there's a combination of both cells, some having the 45X and some having the normal 46XX. So that is what we call mosaic Turner. Moving on to Klinefelter syndrome. So Klinefelter syndrome basically is a condition where you have more than one X chromosome in a male individual. So it could be 47XXY, which is the most common type. You could also have 48XXXY, 49, and so on. It goes on like that. So the general incidence is quite high. It's about 1 in 500 to 1,000 males. And usually the individuals with Klinefelter syndrome, they present with hypergonadotropic hypogonadism, infertility, azoospermia, delayed or incomplete secondary sexual development. Many of them have a Marfanoid habitus. They'll be tall and they could have Marfan-like features. And then the testicular volume is usually small. Many of them also have gynecomastia. 47XXY, they may be, usually they're intellectually normal, but they can have behavioral anomalies and learning disabilities. But the ones who have more X chromosomes, those Klinefelter variants usually have intellectual disability. Now, that was about the DSDs which present with primary hypogonadism, but which do not have. So again, Klinefelter does not have ambiguous genitalia. Whereas the sex chromosome DSDs which present with ambiguous genitalia are mainly these two, the 45X, 46XY mixed gonadal dysgenesis and the 46XX, 46XY ovotesticular DSDs. So mixed gonadal dysgenesis, in fact, is one of the most common causes of genital ambiguity, and the phenotype of the gonads and the external genitalia here would depend upon the proportion of the 45X cells. So you could have variable clinical manifestations. If there are more of 45X cells, you can actually have a Turner-like phenotype only in these individuals, and mostly you will call them Turner syndrome only. But if you have fewer 45X and almost equal number of 45X and 46XY, then they are the ones who present with the typical genital ambiguity, and they can have variable manifestations varying from complete cryptorchidism to partial testicular dysgenesis, hypospadias, and also even persistence of the Mullerian structures. And again, the external and the internal genitalia could be asymmetric also. Usually they also have short stature, and most of them have this increased risk of germ cell tumors also. That is either a gonadoblastoma or a dysgerminoma. And then moving on to the ovotesticular DSDs. So these are conditions where you have both ovarian and testicular tissue present in the same individual. Both could be present in the same gonad, in which case you call it ovotestes, or you can even have ovary on one side and testes on the other side. Again, depending upon the amount of the hormone being produced in fetal life and afterwards, you can have variable clinical manifestations ranging from an external genitalia which looks almost female to almost male to complete ambiguity. Likewise, internal genitalia can be variable, usually corresponds to the ipsilateral gonad. You can have an abnormal vagina ending in a urogenital sinus. Uterus may be present, but it's usually hypoplastic. And some of them may even show signs of menstruation and all at puberty. Usually they will have sterility, but sometimes ovulation and spermatogenesis are possible. So ovotesticular DSDs, actually, there are three main types. You can have the ones where you actually have the mosaic chromosomal complement. Those are the ones which are called chromosomal ovotesticular DSDs, which account for 30% of the ovotesticular DSDs. About 60% you have a normal karyotype of 46XX only. And in majority of these cases, it is not exactly known why they have this ovotesticular DSD, why the testicular tissue is developing. But in some of them, there are some bases identified. About 10% of them, in spite of having 46XX, they actually could have an SRY. And then some of them could even have mutations in the genes which are involved in the embryo determination pathway. Likewise, about 10% of them could have a normal 46XY karyotype and still have ovotesticular DSD. Again, in majority of such cases, the cause remains unknown, but in some, you may have mutations in the SRY, SOX9 or DMRT1 and other genes involved in the pathway. So this is what an ovotestis could look like. So as you can see here, above you are seeing the ovarian follicles and below you are seeing the immature Sertoli cell only tubules. So this is what an ovotestis would look like, where you have both types of tissues in the same gonad. So that was about the sex chromosome DSDs. Now moving on to the 46XY DSDs. Here, the karyotype is that of a normal male. There is no abnormality in the karyotype, but the external genitalia could be ambiguous or it could be almost female-like. Most of these 46XY DSDs will have palpable gonads, that is testes, and these were the individuals who were previously referred to as male pseudohermaphrodites, but nowadays we don't use these terms. So if you look at the 46XY DSDs, there are two main types here: the disorders of gonadal development, where the testis itself is not developing normally. So either you could have a complete gonadal dysgenesis, where the testis is not formed or it's highly abnormal, dysgenetic tissue. So that's called Swyer syndrome. You could have partial gonadal dysgenesis. You could have a testis which was forming normally initially, then for some reason it started regressing, which is called testicular regression syndrome. And then, of course, the 46XY ovotesticular DSDs that we discussed in the previous slides. The other important category is disorders of androgen biosynthesis and action, where the problem is not with the testicular formation. The testis is formed normally, but it's the androgen, the production, which is impaired, or its action, which is impaired. So the gonadal dysgenesis, if you see, some cases we know it's because of mutations in all those genes which are involved in the testis formation pathway. So that is the SRY gene, WT1, SOX9, and some of the other genes we saw in the pathway in the previous slides. But in many cases, the basis remains unknown. So incomplete gonadal dysgenesis, because you do not have the testosterone or the AMH being formed, generally they will have a female phenotype. The external genitalia will be like a normal female external genitalia. The Mullerian structures also will develop normally inside. So they will have the uterus, fallopian tubes, and other Mullerian derivatives because the AMH is not being formed there. Usually they have streaked gonads with an increased risk of gonadoblastoma. And they may be reared as a normal female child and usually present for the first time around in the peripubertal period with primary amenorrhea and delayed puberty as the primary manifestation, and they may be normal otherwise. Partial gonadal dysgenesis, again, to an extent, the testicular tissue may have formed, and depending upon how much functioning testicular tissue is there, depending upon how much testosterone and AMH is being produced, the genital ambiguity will vary, and also the Mullerian structures may be absent or present or underdeveloped depending upon how much AMH has been produced from the partially developed testes. So there are most of these complete gonadal dysgenesis individuals are non-syndromic, but there are some syndromes which are known to be associated with 46XY gonadal dysgenesis. The three common ones, or not exactly common, but the clearly known ones are Frazier syndrome, Dennis-Drash syndrome, and Campomilic dysplasia. In all three, the karyotype will be normal. It will be 46XY only, but it would be a monogenic condition. Mutation in the WT1 gene is responsible for Frazier syndrome and Dennis-Drash syndrome because WT1 is an important gene involved in the testis formation pathway. But here, in addition to the gonadal dysgenesis, the Frazier syndrome individuals will also have focal segmental glomerulosclerosis of the kidney, whereas the Dennis-Drash syndrome patients will have mesangial sclerosis of the kidney and also predisposition to develop Wilms tumor. SOX9 is the other gene, which is an important gene in the pathway of testis formation. So mutation of the SOX9 gene causes something called Campomilic dysplasia, where in addition to the gonadal dysgenesis, you can have skeletal malformations such as bowing of the long bones, 11 pairs of ribs, small scapulae, cleft palate, micrognathia, and other features. So this is a child with Campomilic dysplasia. You can appreciate the bowing of the long bones, and this child also had ambiguous genitalia. Testicular regression is also known as vanishing testes syndrome. So here there is initially normal testicular development, but for some reason, and in majority of the cases, the reason remains unknown, the testes starts regressing between 8 to 14 weeks of gestation. And depending upon the timing and the extent of the regression and how much of fetal testosterone has been produced, you can have again variable degrees of ambiguity, and also the Mullerian structures may or may not be present depending upon how much AMH has been produced in fetal life. But these individuals will have normal 46XY karyotype. So that was about gonadal dysgenesis. Now we are moving on to disorders of androgen synthesis and action. So if we have to understand these disorders, we again now have to go back to our biochem days. So this is one of those pathways which I'm sure all of you hated in biochem. Is always very difficult to remember, very difficult to reproduce. And I'm sure all of us lost marks trying to draw this pathway in the exam. But we have to understand this pathway if we have to understand the disorders of androgen synthesis. So this is the normal pathway of steroid biosynthesis. Okay. So what happens here? Now, if you have a 17 beta hydroxysteroid dehydrogenase deficiency, that's where it acts. So this is responsible for the conversion of androstenedione to testosterone. If you have a deficiency here, there is a block in this pathway. So what happens? There is a deficiency of only testosterone. Everything else is happening normally in the pathway. So these individuals manifest only with reduced testosterone, and because of reduced fetal testosterone in fetal life, they develop, these individuals are actually 46XY individuals, but because of the reduced fetal testosterone, they have genital ambiguity and they present only with DSD. Whereas if there is a deficiency of the 3-beta hydroxysteroid dehydrogenase enzyme, now this is involved in all 3 pathways, right? So if there is a block here because of this deficiency, all 3 pathways are getting compromised. So here there is a reduced production of testosterone, obviously, so you do get DSD here. But in addition, because there is a reduced production of mineralocorticoids and glucocorticoids, you will get salt loss and congenital adrenal hyperplasia also. So this is one of those conditions where this is a 46XY DSD with salt loss, CAH, and the ambiguity. Okay. Now, the next one, CYP17A1, the gene, which codes for the 17-alpha hydroxylase enzyme. Now, what happens? Now, this is involved here in this pathway. So, this pathway is kind of blocked here. So, all of these upstream, these metabolites get diverted to this pathway because it cannot go this way. All of it comes to this pathway. So you have an excess of mineralocorticoids being formed, and these 2 are reduced, especially the sex steroids, there is a reduced production. So excess of mineralocorticoids causes salt retention and hypertension, and also there is a CAH. So this particular enzyme or this particular gene is associated with DSD, 46XY DSD with congenital adrenal hyperplasia. But unlike the 21-hydroxylase deficiency, here you have salt retention and hypertension because of the excess mineralocorticoids being formed. So now you have this child here who presented with ambiguous genitalia, micropenis, there was cleft palate as well, there was microcephaly as well, there were some digital anomalies as well. Any guesses what this might be? There was intrauterine growth restriction and postnatal failure to thrive. Sorry? Anyone? So, no, this is not CH because cleft palate doesn't happen in CH. Sorry? No. This is not campomilic. Actually, there was no bowing of long bones here. There was a general IUGR and postnatal growth restriction, postnatal failure to thrive. So this is actually Smith-Lemli-Opitz syndrome. Okay. So Smith-Lemli-Opitz syndrome is one of those conditions which is actually a more proximal enzyme gets compromised there. So this 7-dehydrocholesterol reductase, which is involved more proximally in that steroid biosynthesis pathway, that is what is deficient here. And because of that, you get a deficiency not only of testosterone, but you get all those other multisystem anomalies because the steroids are essential for so many other normal organ developments also. So here you get DSD along with microcephaly, growth retardation, and all those other malformations I told you about. Likewise, there's another enzyme which is more proximal in the pathway, this P450 oxidoreductase. So here again, if there is a deficiency, you get a problem not only with the production of testosterone, but other multisystem anomalies. And that includes craniosynostosis, skeletal anomalies, renal anomalies, cognitive deficits. And this condition is called Antley-Bixler syndrome. So you could have these syndromic things also in 46XY DSDs with defective androgen synthesis. Now, here we have an individual read as female initially, but started developing, now the individual is 16 years old, started developing enlargement of phallus from 12 years of age. The ultrasound abdomen and pelvis, there was no uterus, fallopian tubes, ovaries. Basically, the ovaries were not there, the Mullerian structures were not there. And there were palpable masses, most likely gonads in the inguinal region. And karyotype was 46XY. Serum testosterone level was normal. So this is not a disorder of androgen synthesis. Serum testosterone is normal. So what could it be? Yes, or 5-alpha, yes. So there are other possibilities, but these are the two main things we will consider here. Either a 5-alpha reductase deficiency or a partial androgen insensitivity. Why have I mentioned partial here? Yes. No, not for that reason. In complete androgen insensitivity also, male gonads will be formed. I'll come to that later anyway. But in complete, yes? Exactly. So complete androgen insensitivity, the external genitalia will be like a normal female external genitalia. There won't be virilization at all. Because the androgen, anyway, I'll be talking about androgen insensitivity in a later slide. But because there is a complete absence of androgen receptors, the external genital virilization does not happen at all. And it will be like a female-like. Whereas here it is ambiguous. So therefore it is partial androgen insensitivity. I mean, these are the two possibilities considered. But after the test was done, the molecular testing was done, which we did through exome sequencing, we found that this individual is actually compound heterozygous for two known pathogenic variants in the SRD5A2 gene. So this SRD5A2 is associated with 5-alpha reductase deficiency. So actually, we will now give a diagnosis of 46XY DSD due to 5-alpha reductase deficiency. And the OMIM, this thing for this particular condition is pseudovaginal perineoscrotal hypospadias, it's called. SRD5A2 gene associated pseudovaginal perineoscrotal hypospadia. So that was the diagnosis in this individual. Now in the pre-lunch session, we had a lot of discussion about this sex of rearing, what to do, all of that. So this individual was reared as a female till about 15 years of age. And then afterwards, once they found out that the person was actually a 46XY individual with testes and all that, the parents wanted to go further and further change the gender, this thing to male. And of course, I think the individual also was probably consulted in that matter, but it was the parents who were very keen on continuing as a male. So that's why though the individual is reared as a female, the initial visit, actually the person came wearing like some kind of, I think, kurta pajama or something. I mean, like a salwar kameez or like that sort of a thing. But after the next visit, the individual came dressed as a male with shirt and pants. So that much of this one. So these are all very difficult decisions, and generally it's best for the family to decide with appropriate inputs from the geneticist, endocrinologist, and the surgeon. So 5-alpha reductase deficiency is actually an autosomal recessive disorder, but it is sex limited. Why is it sex limited? Yes, because it has a role only in male development. Because even though generally autosomal recessive disorders, we say both males and females are going to be affected. But here, the enzyme plays a role only in the external genital development of a male individual, not the female individual. That's why the manifestations happen only in males. Females with these mutations do not have any problems. They do not have any manifestations. So it is a sex-limited condition. And again, going back to our previous thing, we remember, if we can recall, dihydrotestosterone is required for normal masculinization of the external genitalia. So if there is a DHT deficiency, there is a variable degree of under-virilization of the male external genitalia, but the testes are intact. Usually you will find them in the inguinal canal. Sometimes those labioscrotal folds also you'll be able to find them. And the Wolffian duct differentiation will be normal. So internal male genitalia will be normal. AMH is normally produced, and hence all those Mullerian structures will be absent. So internal genitalia will be like that of a normal male individual. Gonads will usually be palpable. That is, a palpable testes would be there. It will be mainly the external genitalia, which is ambiguous and under-virilized. And this is the other condition that we were discussing. So this is a disorder of androgen action, where the androgen receptor coding gene is actually having the mutations. So depending upon how severe it is, it could be a partial or a complete androgen insensitivity. In partial, there will be incomplete virilization, whereas in complete androgen insensitivity, it will be a female-like external genitalia. There won't be any virilization at all. And here the testes would be normal. AMH is normally produced, so the Mullerian structures, the uterus, fallopian tubes and all that will not be present. And most of these individuals with complete androgen insensitivity are reared as females and present usually at puberty with primary amenorrhea. Some of them may present with inguinal hernia. In the sense, it is not really inguinal hernia. So you'll have a female individual noted to have some mass-like thing in the inguinal region. It will be usually assumed to be a girl with an inguinal hernia, will be brought to the attention of the doctor, and afterwards it comes to light that it is actually the testes and it's not a hernia. So this is one presentation of these individuals who have DSD, who have were actually 46XY, who have testes, but who are reared as females because the external genitalia is like complete female-like. They can have this presentation they're brought to attention with apparent or suspected inguinal hernia, which is actually nothing but the gonads in the inguinal region. So now if you look at this particular pedigree, what would you tell me about the possible inheritance pattern here? Sex-linked dominant. But then this particular individual is not affected now. This is not sex limited. Anything else? Any other? Anyone else? Okay. So actually, if I tell you that, this, when you take the history, it's like this. But after you do the test, you actually find out that these individuals are 46XY and they are reared as females because they have female external genitalia. Then it becomes obvious X-linked inheritance, isn't it? So this actually androgen insensitivity has an X-linked recessive pattern of inheritance. But quite often what happens is, especially in complete androgen insensitivity, I told you, the external genitalia is like complete female-like. There's no ambiguity, so there's no cause for suspicion. And they may come for the first time saying that this individual is a girl child who is having, primary amenorrhea. So then if you take the history, they may say that, yes, there are some two maternal aunts who also have primary amenorrhea, who never got married or who have something like that. And then it has happened.
And patient came to me, 3 sisters, all of them having the same.
Yes, so it does happen. And in fact, in the olden days, there was not much awareness. People were not evaluated. Most of them, they were like primary amenorrhea, so they would not get married and nothing would be done about them, further saying they're otherwise healthy and okay, so let's not do anything about them. And they never got evaluated, so this thing never came to light. So these kind of things can happen, where you can have this girl or apparently like raised as a girl individual and 2 maternal aunts in the family, all of them giving history of primary amenorrhea. Actually, it could be a 46XY DSD with completely like female-like external genitalia, and especially for complete androgen insensitivity, this sort of thing happens because androgen insensitivity has an X-linked recessive pattern of inheritance. So that was about the 46XY DSDs. Now moving on to the 46XX DSDs. So these individuals have a normal female karyotype, and the ambiguous genitalia is due to virilization of the female external genitalia. These were the individuals who were formerly called female pseudohermaphrodites. So here, again, two main categories. You have the disorders of ovarian development. So this includes your 46XX ovotesticular DSDs. Then the testicular DSDs where they are 46XX, but they have like maybe duplicated SOX9 or SRY plus, because of which they have testes, not even ovotestes, but testes, in spite of being 46XX. And then you have the gonadal dysgenesis again. And then you have this other important category of fetal androgen excess. So here, the most important cause is congenital adrenal hypoplasia due to 21-hydroxylase deficiency. And the other one is 11-beta-hydroxylase deficiency. Without congenital adrenal hypoplasia also, you can have fetal androgen excess, especially if there is a placental aromatase deficiency or maternal androgen intake during pregnancy, or a maternal androgen secreting tumor. So now here we have a newborn with ambiguous genitalia, clitoromegaly, as you can see, partially fused labioscrotal folds, no palpable gonads, generalized hyperpigmentation, and especially the genitalia appears hyperpigmented. Karyotype is 46XX. What do you think is the most likely diagnosis? CH due to 21-hydroxylase deficiency. So that would be the first diagnosis to consider. And what we would do here, and I'll tell you why later, we would do a targeted sequencing plus MLPA, multiplex ligation dependent probe amplification study of the CYP21A2 gene. And by doing that, we did find that the child had compound heterozygous variants in the CYP21A2 gene, two pathogenic variants. And by that, we were able to confirm that this was indeed the diagnosis. So I'll come to why we do that test later, but I'll just take you back to this pathway to understand what happens. So here, CYP21 is involved in these two pathways, okay? The conversion of this, progesterone to aldosterone and 17-alpha-hydroxy progesterone to glucocorticoids. So now if you have a mutation here causing deficiency of this enzyme, this pathway gets blocked and all of the metabolites get shunted to this third pathway and it comes here. So you have an excess of testosterone being produced in a 46XX individual, and in fetal life, if you have excess of testosterone being produced, that causes virilization of the external genitalia of the female fetus. And because these two pathways are blocked, there is a deficiency of mineralocorticoids and glucocorticoids. That's why you get this salt-losing presentation, the salt-losing crisis. So 90 to 95% of 46XX DSDs are actually because of 21-hydroxylase deficiency. So if you get a 46XX DSD, the first default diagnosis you should think of is CH because of 21-hydroxylase. Only if that is ruled out, you begin to think of other possibilities. And why is it important to think of this as the first possibility? Because 75% of them have salt-losing crisis, which is potentially life-threatening and a medical emergency. So if you miss that, you can lose the child. So the first possibility you should think, if you have a child with DSD, with ambiguous genitalia, without palpable gonads, even while you're waiting for your karyotype report also, without, like you can first, if gonads are palpable, it is usually not 46XX DSD, then it will be mostly 46XY DSD, because ovaries will usually not be palpable, only testes will be palpable in the inguinal scrotal folds. But if you do not have palpable gonads, it is very, of course, there are other possibilities, but clinically always first think of 46XX DSD and evaluate for this first, and then other things, of course, simultaneously you can evaluate, because this is a potential medical emergency. So the presentation could be of a baby with ambiguous genitalia, clitoromegaly, fused labioscrotal folds, but without palpable gonads. And generalized hyperpigmentation is usually seen, especially of the external genitalia, you'll have hyperpigmentation. And about 75% of them have salt-losing crisis with dyselectrolytemia, which can be potentially life-threatening and requires early diagnosis and management. And please remember, as I said before, every newborn with ambiguous genitalia without palpable gonads, think of this possibility and evaluate for this first. And please also remember that affected males with 21-hydroxylase deficiency do not have ambiguous genitalia. So you will miss those cases. Hence, it is absolutely essential to do routine newborn screening through serum 17-hydroxyprogesterone assay for every newborn, because at least in a female child, you will pick up because of the genital ambiguity, whereas in a male child, there will not be genital ambiguity in 21-hydroxylase deficiency. They can have, subsequently, they can have precocious puberty-like features, but they will not have genital ambiguity, and you will miss those unless you do the routine newborn screening. So please remember to do that in each and every newborn. So this is the most common form of congenital adrenal hyperplasia. This is an autosomal recessive disorder. Biallelic pathogenic variants in the CYP21A2 gene is the cause, and clinical presentations can vary. The typical one is like with the female baby virilized at birth with ambiguous genitalia, but sometimes some of these individuals may become virilized postnatally. They can have menstrual abnormalities, they can have reduced fertility. In males, as I said before, there is no genital ambiguity, but they can have isosexual pseudo-precocious puberty. Also, salt-losing crisis is seen in about 75% of them, and many of them have advanced bone age with increased linear growth. But as adults, they tend to have short stature because of premature epiphyseal fusion. So management, prompt endocrinology consultation, glucocorticoid replacement therapy, this has to be increased during periods of stress. In the salt wasting form, you have to give the mineralocorticoids along with sodium chloride supplements, and also explain to the parents about all the sick day management and all the danger signs, and monitor and tell them how to monitor for symptoms and signs of salt losing crisis, and bring the child immediately to the hospital if they notice any such thing. And females who are virilized at birth may require feminizing genitoplasty and or vaginal dilatation subsequently. Primary prevention is always the best. Hence, early diagnosis and intervention through routine newborn screening, checking 17-OHP in each and every newborn would be really ideal. So coming back to why we are doing that thing of targeted sequencing and MLPA. So the genetics of CYP21A2 is very complex. It has a pseudogene, okay? And some of these variants, which we find as pathogenic variants in the gene, are actually present also in the pseudogene. In addition, you can have large deletions, which involve the gene partially and the pseudogene partially. You can have complex rearrangements involving the gene and the pseudogene, and you can have something called gene conversion, where you get new sequences as a result of these rearrangements. So many different kinds of mutations can happen in this CYP21A2. So the genetics is very complex. So you will, if you were to do just a simple exome sequencing, you may miss many of these kinds of mutations. That's why you should actually do a long PCR first to selectively amplify only the gene and make sure that the pseudogene is not involved in your product. And then that selectively amplified gene alone without pseudogene should be sequenced for sequence variants. And MLPA is done to look for all these large deletions and conversions. So by doing a combination of this long PCR followed by targeted sequencing of the gene without excluding the pseudogene and the MLPA, you can pick up the mutations. Okay. So now I'll just take you through this evaluation of a patient with DSD. First and foremost, always, as for all our clinical cases, a detailed history of growth, development, associated systemic complaints, prenatal history. So if a newborn is there with ambiguity, you have to ask for history suggestive of maternal exposure to androgens, any maternal androgen secreting tumors, then a detailed family history with 3-generation pedigree, history of ambiguity, genital ambiguity in the family, hirsutism, precocious puberty, amenorrhea, infertility, unexplained sudden infant death, or consanguinity, because consanguinity does increase the risk of many of these rare autosomal recessive disorders. Why unexplained sudden infant death? Yes, salt-losing type of CAH with dyselectrolytemia. Then physical examination, thorough examination of the genital anatomy, the groin and labial scrotal folds to be checked for presence of palpable gonads. As I said before, most of the cases, if you get palpable gonads, they would be testes only. Ovaries and streak gonads do not descend and will not be palpable. Rarely ovotestes may be palpable, but generally if you get a palpable gonad, it is a testes. Phallic size has to be measured, stretched length has to be taken, width has to be measured. Complete general and systemic examination for syndromic entities, including anthropometry, dysmorphology evaluation, systemic examination, And then newborns with ambiguity, you look for any abnormal virilized or Cushingoid appearance of the mother to see whether there was any androgen excess in the mother. And if you're going to be doing photography, please do that with a great degree of sensitivity and with the consent of the individual and the parents. So in the neonatal period, you can have overt genital ambiguity, apparent female genitalia with enlarged clitoris, posterior labial fusion, apparent male genitalia with bilateral undescended testes, hypospadias, micropenis, or in our country, of course, prenatal karyotyping, sex determination, sex revealing is not allowed. But in the countries where it is allowed, they may have done the karyotyping antenatally for some indication. They would already be knowing that it is a 46XX or 46XY individual. And then after birth, they find that the genital appearance is discordant to what was expected. So that is one of the ways it is picked. Ultrasound also, yes. You cannot disclose, exactly, precisely. Sorry?
Even there will be ultrasound and they already.
No, karyotyping for some other indication, I'm telling. In the countries where prenatal sex disclosure is not banned, they may have done karyotyping for some other indication, such as a positive double marker or whatever it may be. And they may already know what it is, and they would disclose, they will reveal it to the couple also, where it is not, where it is permitted to. And the couple would already be aware that this is going to be a girl child or a male child, depending upon what was told to them. And then they find the genitalia is discordant with that. So these are the various ways it could present. Later presentations, previously unrecognized genital ambiguity, inguinal hernia in a girl, I showed you, in a individual reared as a girl, rather. Then delayed or incomplete puberty, primary amenorrhea or virilization in a girl, breast development in a boy, gross or cyclic hematuria in a boy. So why would that happen? So, yes, so basically individual reared as a male child, as a male, and actually having the Mullerian structures inside, and may have the menstrual bleeding, which is mistaken to be cyclic hematuria. So all these kinds of presentations could happen. The first line tests are always the imaging and the cytogenetic analysis. So imaging, you would do the abdominopelvic ultrasound with or without MRI. So this helps us to look for the Mullerian Wolffian structures internally to detect the testes in the inguinal scrotal region. But it is, I think you can actually give us more this thing on clarity on this. I believe it is not useful for intra-abdominal testes, right? USG scrotum, you can detect this thing, labioscrotal folds, but intra-abdominal testes, I think ultrasound cannot pick up, but MRI can, I think.
Yeah, ultrasound.
Yes, ultrasound cannot, MRI can. Yes.
Sometimes.
Okay. And then also you would like to rule out any adrenal enlargement and so on. And some of them may have associated renal anomalies, so you would want to look for those as well. Karyotyping has to be done in all cases because it gives you clarity as to whether it is 46XX or 46XY, because based on that, you can work them up further. And also in the case of a sex chromosome DSD, by doing a simple karyotype itself, you will get the complete diagnosis and you don't have to do any further workup for etiology. If you get a clear picture of a mixed gonadal dysgenesis on karyotype, you don't have to evaluate further for the cause. So now, if you have this 46XY, no testes, plus or minus Mullerian structures, what do you think could be the possibilities? So this is more like a, so basically this is like a complete gonadal dysgenesis, where it is 46XY, but the testes are not there. And Mullerian structures may be there because of AMH not being produced. So here, one of the known causes is SRY deletion. So that is what you can do first, FISH or MLPA to look for the SRY. But there are cases, as I said, in non-syndromic, if it is syndromic, you could do mutation analysis of the relevant gene, like SOX gene if you're suspecting campomylic dysplasia, or WT1 if you're suspecting Frazier or Dennis-Strash syndrome. But if it is non-syndromic and SRY is intact, then you can have mutation in one of these other genes, NR5A1, DHH, Wnt4, but in a big proportion of cases, the reason remains unknown. So you may not always be able to identify the cause. Now, if you have 46XY with testes without Mullerian structures, what is the most likely possibility here? Disorder of androgen synthesis or disorder of androgen action. Yeah. So, yes. So basically here you would do the basal and post HCG stimulation testosterone and dihydrotestosterone assay. Normally you expect a threefold elevation of testosterone over baseline with HCG stimulation. If you do not get an expected elevation and with a high FSH-LH, generally means that there is a testosterone biosynthesis defect. If you get a normal testosterone level, it could either be an androgen receptor issue or a 5-alpha reductase deficiency. So you check the testosterone to dihydrotestosterone ratio. If testosterone is high but DHT is low, that means it is most likely 5-alpha reductase deficiency because there is a conversion problem only. And then you can look for mutation in the SRD5A2 gene. If testosterone is normal, dihydrotestosterone is normal, the ratio is normal, most likely it is androgen insensitivity. You can look for mutation of the AR. But then having said that, it's not so easy to do these hormonal assays. The lab may not be very reliable, and doing all this post-HCG stimulation, testosterone, dihydrotestosterone assays and all, because you're basing the diagnosis on that, if the assay is not reliable, then again, you will end up with a wrong diagnosis. So, no, FSHLH will be normal because testosterone is being produced normally. So only in the disorders of androgen synthesis, FSHLH will be high. So the thing is, even though this is the ideal way to go about it, but nowadays, because we have these broad spectrum tests available, NGS-based tests are available, quite often we bypass all these things and directly go for, roughly we narrow down to it might be a disorder of androgen synthesis and action, but then we generally go for exome or something, try to identify the mutation. Then as a corroboration, you can come back. Like if you get a clear pathogenic variant, you have a diagnosis there. But as in the morning, we were discussing if you get a variant of uncertain significance and you want corroboration. So suppose you were to get a variant of uncertain significance, a homozygous variant of uncertain significance in the SRD5A2 gene. How do you confirm that? You can look for corroboration by doing this. You do the testosterone DHT levels, check the ratio, and say that, yes, it is corroborating with what I found. So you could do it that way also. Okay. Whereas if you have a 46XX with normal ovaries and normal internal female genital organs, the first thing you would always think of is 21-hydroxylase deficiency. So first you will do 17-hydroxyprogesterone assay. In the classic form, you'll have a very high elevation. In the non-classic form, you may have to do ACTH stimulation to document this. The other parameters you could look for, but which are not really readily available assays, include serum 11-deoxycortisol and deoxycorticosterone, which are elevated in 11-beta-hydroxylase deficiency, but reduced in 21-hydroxylase deficiency. Likewise, if available, you could do urinary pregnant trial as well, which is supposed to be increased in 21-hydroxylase, but again, not a very readily available assay. So generally, most of us go for this molecular genetic confirmation only. So generally, what are the tests that are done? Sanger sequencing, if you want to look for individual small genes, or if you want to specifically test for specific variants. If you want to look for multiple genes, large genes, whole exome, you do NGS-based testing. And if you want to look for large exonic deletions, duplications, you do the MLPA test. So after the genetic testing and confirmation of the genetic etiology, genetic counseling is provided regarding the natural history of the disease, the prognosis, the management options, appropriate referrals to the endocrinologist, pediatric surgeon, urologist, plastic surgeon, all the associated issues if it's a syndromic condition, long-term monitoring, surveillance, recurrence risk for other subsequent pregnancies, all of these are discussed. And then the reproductive options are discussed. So this how to rare is always an issue, which we discussed in the morning. And most of these 46XX and 46XY DSDs, which are caused by single gene defects, the disorders of biosynthesis, androgen biosynthesis, and all those CH conditions, most of them have an autosomal recessive pattern of inheritance, where both parents will generally be carriers, and there would be a 25% risk of recurrence in each offspring. For some of those conditions, the phenotype may be sex-limited. The example we discussed was 5-alpha reductase deficiency, where you get the phenotype only in the male individual. Androgen insensitivity, I showed you that pedigree is X-linked recessive. And some of those things like SRY, of course, is Y-linked, but otherwise, campomelic dysplasia is autosomal dominant. Now, prenatal management is the last thing I'll cover. So this is for, this is not really followed so much in India, because generally in India, the tendency is that if they find the fetus is affected, they would generally go for termination. But if the couple wishes to continue the pregnancy, let's say they've had a previous child affected with CAH, 21-hydroxylase deficiency, they know that the risk of recurrence for the next child is 25%. but they are okay with continuing the child, but they want to minimize all these virilization and things like that. Then what you can do is about 9 weeks after the last menstrual period, the lady can be started on oral dexamethasone in 3 divided doses, which is about 20 micrograms per kg of the pre-pregnancy weight. Then you do CVS at 11 to 12 weeks or 13 weeks of gestation. Of course, this step is a bit problematic in India because it's not allowed in India. Even there are some clauses where it says that you could reveal, but there's a lot of gray area here. So most people would not like to reveal what the gender is. So, but in places where it is permitted, if they find that it is actually a male fetus which is not, I'll address your this thing. Male fetus which is not affected, anyway, you don't have to do it. So you'll do a CVS with a targeted mutation analysis and the gender, whatever, to see whether it is male or female. Now, if it is a male fetus without CH, obviously you will stop the dexamethasone. Female fetus without CH, you will stop the dexamethasone. Male fetus with CH, also you will stop the dexamethasone because there is no risk of virilization there. And only female fetus with CH, you will continue the thing till term. After term, you will start all the things from the mineralocorticoid, glucocorticoid supplements from the newborn period. So this is what could be done if the couple wish to wish to continue the pregnancy. But if they're anyway planning for termination, if the fetus is found to be affected, then probably all this is not required. You do it the usual way. You do the CVS. You find obviously there you're not going to disclose the gender. You just say the fetus is affected or not affected. Any fetus which is having both the biallelic for the pathogenic variants would be affected. And once you disclose that to the couple, they may opt for termination of the pregnancy. So you had a question? Yes. Precisely. Yes, yes, that's right. So basically, disorders of sex development are genetically heterogeneous. Sex chromosome DSDs are caused by chromosomal anomalies. 46XX and XY DSDs are mostly of monogenic etiology. So therefore, there is no single genetic test for all DSDs. But karyotyping is the essential first genetic test for all of them for ascertaining the chromosomal sex and for diagnosing sex chromosome DSDs. But obviously, it will not give you information about the monogenic etiology. And accurate diagnosis helps in appropriate management, accurate prognostication, accurate genetic counseling, and prenatal testing. So now if we have time, I'll just ask you 4 questions. Okay? Okay. So the term disorders of sex development refers to, which one is correct? A, B, C, D? D, yes. So it's an umbrella term which includes ambiguous genitalia as well as primary hypogonadism. Okay. Which one of the following is a sex chromosome DSD? Sorry? Not us. What did you say? Yes, yes. C, mixed gonadal dysgenesis. Okay, which one of the following statements is not correct about 5-alpha reductase deficiency? Not correct. Yes, so C is incorrect because AMH is normally produced, so Mullerian structures will not be present. And which one of the following is the most common cause of 46XX DSD? 21-alpha. Congenital adrenal hyperplasia due to 21-hydroxylase deficiency. So that's all. Any questions?